Hello, Dr. Ochoa. Thank you so much for finding the time to talk with me, and congratulations on the Harry Hines Award.
Thank you, Paul. It's a pleasure being here, and it was a big surprise to tell you the honest truth. I had no idea that something like this was coming, but it was a pleasant surprise, definitely, for some of the work that our group and our team has done over here.
How long have you been involved in NCORPs or CCOPs?
So, this was all by accident. After Hurricane Katrina, you remember we were underwater essentially, lost all our operating capacity. Our oncologist left, and I was just running the tumor immunology program at that point here at LSU, just creating it, and the director of the cancer center left, and so the chancellor said, now you're it, you're the only one who has a good relationship with the NCI. Let's see if we can make some of these things work. And then the last oncologist we had brought me a folder and said, this is the CCOP. I just notified the NCI that they should close it because I'm leaving. And I said, what does CCOP stand for? I didn't even know what CCOP stood for. So she took about 30 minutes and explained to me what it stood for. And I said, well, I don't think you can close it because this is the lifeline for our patients. It's not your grant. It's really an institutional grant. Let me talk with the NCI. Who should I talk with? And she said, well, call Dr. McCaskill-Stevens. Okay, I'll call her. So I called Warda and I said, I'm going up next week for, I think, a study section or something like that at the NCI. Can we meet? So I went there and met with her, and I explained to her what we had. And I asked her, I said, would you mind giving us a chance to restructure the CCOP, which was at that time only working in two sites, our primary medical center, which at that time was Charity Hospital in New Orleans, and our children's hospital. And that was it. I asked her, would you let me try to restructure this and see if I can make it work? If in 12 to 18 months it doesn't work, then I agree, then let's close it. And she looked at me. I obviously probably had this deer in the headlights look because I had no idea how this was going to happen. But she said, yes, we'll support you. And we came back, and that was in 2006, end of 2006. We had a first meeting with community oncologists, September 15th, 2006. I remember that date. And we invited them to the cancer center. We had a little dinner with them. And I said, look, we've got this great grant from the NCI. It allows us to offer clinical trials to patients who would otherwise not have access to clinical trials. I don't have the oncologist to run that here, but since you are seeing the majority of patients in the community, would you be interested in having access to these trials for your patients? We will run the grant. We will do all the regulatory. We will do all the data management. We will split with you a little bit of the funding that we get so that you can hire maybe part of a nurse or something like that. And the only thing that I ask that we follow all the rules and regulations of the NCI, and we will work together with that. And one group signed up. A private cancer center up in Baton Rouge called the Mary Bird Perkins Cancer Center, and one private oncologist in town. And we started with that in 2006. And since then, it's grown and grown and grown and grown. And now it's a statewide program with 50 sites throughout the state and the state of Mississippi, and a very good group of collaborators.
How many patients are you putting on trials? How many trials?
So we have somewhere between 75 and 90 trials altogether. So the structure, the way we set it up was as partner organizations want asked to participate. So first we had those two groups. Then we had LSU Shreveport wanted to participate. Then we had the largest clinical provider in the state, the Ochsner Medical Center, asked to participate, and that's how we build it. So each one of those sites sees very different patients. So this is a federated system of selection of trials. We open the trials that the groups think are interesting, but each group decides what trials they adopt or they open and they manage. Because, for example, at the Ochsner Clinic and at the Mary Bird Perkins Clinic, they see mostly insured patients, and so tumors tend to be less advanced. Instead, LSU Shreveport and us see the more advanced cases. So the types of trials are different. So we have anywhere between 75 and 100 trials open. We've grown from, we enroll about 1,600 patients a year throughout the state.
Wow. And then throughout 2 states, right?
Well, it's mostly Louisiana, and then we have a few spots in Mississippi.
Is that one of the largest, you think?
I don't know in terms of total numbers. I haven't compared it. We have grown many fold. We grew from about 40 to 60 patients a year to about 200 patients up to 2014. And in 2014, when we started the NCORP and started bringing the other partners on board, then we've grown rapidly. In the last 4 or 5 years, we've basically plateaued at about 15 to 1,600 patients a year.
That is really an astounding success. So that it must have been very much like what Harry Hines said to have gone through in Wichita, because there it didn't even exist. And
Yes.
He's in the first bunch of CCOPs. It's kind of an amazing thing. And there you are, you kind of walk in, what's a CCOP?
That's exactly right. That's it. So, and I think it's grown basically based on trust. We allow people to, the idea initially when we first floated the idea, some of the oncologists, local oncologists said we won't work with the university because the university will absorb our patients, but we did not have oncologists at that time. I'm a pediatric immunologist by training. I wouldn't take any of their patients anyway. And so over the years, they realized we're not taking their patients. We're bringing clinical trials to the sites so they can offer the trials to their patients. And that's worked so far. It's worked well.
Mm-hmm. What about, it is a minority CCOP, so that must be very interesting to be working with this now that this is actually the single most important issue in oncology, is how to deal with disparities. You've been dealing with nothing but disparities for a long time.
That is correct. And I think that, the 4 partner institutions that participate in our NCORP are very much committed to making sure they address the issue of disparities and make sure that they offer access to clinical trials to underserved minority populations. So the average enrollment of minorities throughout clinical trials is somewhere in the order of 3 to 5% throughout the nation. We enroll 55% of our patients are minorities in our clinical trials. And in some of our trials, for example, the TMIST trial that you know pretty well, is our enrollment of minorities is about 72%.
72% of
That's
TMIST.
correct. Yes,
and
that is correct.
That is really an astounding number.
Yeah.
So you have a lot to teach the rest of the system, basically.
Yeah, it's interesting. This has happened at this point without much. We've just started really trying to work out on the community outreach program to inform people even better. So this has really happened because we are maximizing the opportunities for patients who actually access our services in our community hospitals, in our university medical centers, and places of that sort. But we do have some really innovative programs going on. One is a partnership with an HBCU, with Xavier University. They have a very large community outreach program because they train the majority of the pharmacists in the state of Louisiana. And so through those pharmacies, they are taking out the message and they're doing their community meetings and telling them about what TMIST is all about and sharing information. So we have our group goes out there, our group of nurses and clinical trial coordinators go out there and work with Xavier for this. The group from Shreveport, from LSU Shreveport, that covers the Mississippi Delta, which is a very underserved, poor area of the country. They have these mobile vans that have the mammography equipment on them, and they go to the communities out in the Delta and do the mammographies for them there. And actually, the person who leads this is a senior population scientist, Dr. McClarty. This year got an award with the NCORP because of for the highest enrollment of patients in TMIST.
Oh,
so those have been very successful, sort of innovative approaches of trying to reach the community rather than just us staying in our ivory towers.
mm-hmm. Oh, that is fascinating. What about I want to get to a bunch of policy questions, but first can we deal with COVID? How did COVID affect you? And then we go policy whole hog.
Well, COVID was a big hit. Um, so different. So as I said, we have 4 partner institutions. Some of the institutions were hit harder than others. We were able to keep the core of our personnel locally because we had we developed a flexibility policy so that they didn't have to be here every single day, but we made sure we still screened the clinics and the patients who were the screening programs like TMIST and some of them, we still maintained them open because we thought those were very important to offer those screening capabilities for our patients. The head manager of the program, Eileen Medeiros, was a trauma nurse originally, and then became a clinical trials coordinator for us, maintained the cohesiveness of the group by actually holding what she would call huddles, like the football huddles. So she would, every morning, they would talk at 8:30 in the morning. What are we doing today? And everybody had a chore, whether they stayed home and worked from home, or whether they came in, or whether they were following patients. That way they maintained the cohesiveness. So overall, although we had some dips in the enrollments, we were able to maintain that. Now, what hit us the hardest is more recently, and that is the changes in the work structure. So working from home, the CRO companies are hiring people left and right, especially when they have a little bit of experience, and they can work from home and make 2 or 3 times the salary that we can offer, things of that sort. So we're slowly trying to adapt to that, and that has required that we build in flexibility in their schedules, especially if they don't have to be here every single day. They're doing regulatory work, if they're doing data management, they don't have to be in the office every single day. So that part has been the hardest, but we were able to maintain that. Now, the other thing that happened that I thought was very interesting is we asked the NCI, when the NCI said, we want to know what the impact of COVID is on our patients, we asked them to fund us, give us a supplement so we could build a COVID cancer registry. And we build that through the tumor registry, which is embedded here. Our state tumor registry is embedded here at LSU in the Cancer Center. And so they were able to link those 2 databases and were able to find patients who were diagnosed with cancer back in the 1990s, who had survived and were alive and doing well, who then developed COVID. And so they're now putting the first publication together on those studies. But that was very informative of what was happening to our patients.
Oh, so how many people do you think you have lost in terms of your staff? And the money, what's their money impact to that, or how were the enrollments affected? Do you have those numbers?
So for the most part, we had a drop in the about the second year of the enrollments in the most severe times of COVID. We had a drop of about 50% of our enrollments, but that only lasted for a relatively short period of time, 2 to 3 months, and then it started to come back. What has hit us more, as I said, was the loss of personnel. And so there have been times where we've lost not just our research personnel, but personnel who were involved in actual providing services in the hospital, or mammographers, for example, or data managers. And there was a point where we lost 50% of our folks to other opportunities, not because they didn't like the work, but because they had other opportunities. And so we've slowly started rebuilding again. But remember, every time we hire somebody like that, they have to go through a process of training, because clinical trials is not, it's almost an apprenticeship from the person who has a little bit more experience than you do.
Well, plus, I would think that drug companies and CROs really want people that you train because they know how to handle diversity.
Yes, that is one of the major things. We have not only had them try to recruit some of our folks, but actually approach us to do collaborative research with them because of the numbers of minority patients that we have been able to enroll on clinical trials, because these communities have built a rapport with us. And so we build trust. And so instead of just thinking that there's somebody is experimenting on them, they know that this medical group, this medical community, it is looking for their well-being overall.
So I would be essentially, if I were working for a CRO right now, I would be rating you for a staff.
Don't say that too loud.
Okay,
The answer is yes.
Yeah, I should have whispered that one.
Yes.
But so I guess this is a kind of an amazing time in oncology, because for the first time, really ever, there's NCI director is actually a cooperative groups person, a group chair. This is an amazing time. So how would you, if what do you see that could be improved in clinical trials from where you sit in your part of the world? We're not trying to give her advice, but just what do you see?
Right. So I think this is a great opportunity having Monica Bertagnoli lead the NCI. I think she brings the perspective of the cooperative groups. I think she understands the need to bring discoveries from the NCI designated cancer centers into real world oncology, which is where the NCORP sits, and the other clinical trials programs. What I think has also happened over time is that we've realized that clinical studies are not just treatment studies, but there's all these other aspects of implementation science, cancer care delivery, things of that sort that are very important. And I hope that what we can do is we can expand the participation of non-oncologists on these clinical studies. 90% of oncology patients are diagnosed and treated in community practices. As a matter of fact, what we find is that many of our patients, whether it's patients with gynecological malignancies, with prostate cancer, with colorectal cancer, are not diagnosed by oncology services. They're diagnosed by general practitioners, general surgeons, OBGYNs that are doing their annual pap smears, things of that sort. And so I think that if we build an opportunity for them to participate in some of these studies, especially all the prevention studies, early detection studies, even simple treatment trials, I think that would expand the impact of the world of oncology even more. So I'm hoping that that's one of the things that happens. I think we have a robust program with the NCORP program and with the NCTN program. And I just think that we need to find ways to bring in these other practitioners that are not necessarily oncologists per se.
Yeah, there's ways to do it and ways not to do it. Recently, I did a story that was actually the most recent BSA meeting that NCI brought forward a proposal to set up a new cooperative group, essentially, to focus on MCED. I'm not asking you to go into the weeds there at all. Let's just forget the weeds.
Mm-hmm.
Just kind of looking at the entire sort of picture. Is there a reason to set up a new infrastructure, or should we be using while the clinical trials groups are being underfunded, or should there be the same infrastructure because you're able to deal with it? I'm not hearing you complain about it.
Yeah, so I don't know I don't want to get into the policy issues because I don't know the background of all this discussion. And I think that I'm sure there's been groups thinking about this one way or the other. And so I don't necessarily know about it, and so I don't want to get into it. But what I do think is that so far, the way we've worked with the NCORP program and with the NCTN program has worked very well. I think, could it be improved? Of course it can be improved. Will more funding help us build more robust programs? Yes. And bringing, again, oncology discoveries to real world oncology, I think we could benefit from that. So I'm not sure that we need to create a new program per se, but I think we can expand existing programs by bringing in non-oncologists into the field to play an essential role, because not everything that is related to oncology, especially prevention and early detection, requires an oncologist to be present or to lead those efforts.
Mm-hmm. Well, I guess an example might be TMIST because it brings in a whole bunch of people. Did you have any trouble recruiting into TMIST or working with other specialties to get people into TMIST?
No, on the contrary, we have in most of the sites that we have that are participating on TMIST, it's actually led by non-oncologists. So we have at our main campus here at the University Medical Center, it's 2 radiologists and a breast surgeon who lead the program there. At Shreveport, it's a population scientist who leads the program with the rural communities. So we don't necessarily have oncologists leading TMIST. This is a good example, exactly, of the type of trials that could benefit from the participation of non-oncologists who see patients at different stages rather than a patient who already has cancer.
Yeah, and this is also a very difficult to accrue and difficult to conduct trial. And you're saying that you're not having any difficulty really, and the numbers are incredible.
Yeah, I would say that we benefited. I'm sure that if we dove further into it and created a more robust community outreach, which we're trying to do with these partnerships with Xavier University and other organizations, I'm sure we would get even higher numbers of patients. But so far, the patient population that has participated, we have not had any difficulty or much doubt of the people who want to participate. They get offered the possibility of participating in the trial, and most of them acquiesce to the participation. So I think it hasn't been difficult, and it's been, again, managed by non-oncologists.
Mm-hmm, mm-hmm. So no reason to create a new infrastructure and a new anything on this, probably.
I would venture to say no, but the truth of the matter is I have not thought through the whole process, and whoever the groups that brought this up might have some specific reasons why that I am not aware of. So I wouldn't want to say it one way or the other. What I'm trying to say is I think we need non-oncologists to also participate, especially in these early stages of prevention and early detection.
What about MCEDs? Have you thought about them much? Is that an important question?
Yes. So we are starting to right now. Our groups are starting to explore those opportunities. We are looking at one of them. There's one of our partners is looking at a second one. So we haven't done this NCORP wide. The individual partners have started to explore these, but we don't have much experience. We're just starting to explore these opportunities.
Oh, that's fascinating. Um, well, you're a pediatrician, speaking of non-oncologists. Does that matter in this situation in terms of what you do? Uh,
Um, it matters in the sense that I have to have very good partners on the adult side. And
uh,
I have been very, very fortunate to have an incredible group of partners on the adult side, both at our campus here at LSU in New Orleans, as well as the partnership institutions at Oxnard, Mary Bird Perkins, and LSU Shreveport. It's interesting because in a state like this, historically, there was no collaboration or between these different institutions in terms of these types of clinical trials programs. But through the NCORP, we've been able to bring them together. And even though they continue to be fierce competitors in the healthcare market, when it comes to the NCORP, we're all able to sit down and put together our heads of what is the best for our patients. So it's not being cancer center centric or institution centric, and it became more patient centric. What can we bring? What are the opportunities of things we can bring to our patients that they would benefit? And I mean, my partners in the adult oncologists and the pediatric oncologists, because we also have a group of pediatric oncologists, have been very collaborative, willing to share their opinions, their experience, their expertise, again, in institutions that continue to fiercely compete for patient populations.
are you the only pediatric, immunologist, definitely? Is there a pediatric oncologist running an NCORP anywhere?
Yes, at least that I know, Anne Marie Langevin in San Antonio
Yes,
runs that. That is a pediatric oncology NCORP, and
yeah,
Anne Marie is a dear friend, and
yes.
she's done extremely well. We actually now have a joint program for adolescent and young adult cancers for AYA, because in order to have sufficient numbers of patients and discussion among the teams, we decided to bring together our two teams, the one from San Antonio NCORP and our NCORP, and they have regular monthly meetings and have started a big AYA program jointly. So I think that has benefited a lot.
She did win the Harry Hines Award a few years back, and I spoke with her about it some years ago. But so you're the only pediatric immunologist, and she's the only pediatric oncologist running an NCORP.
That I know of. I don't know of any other pediatric immunologist running an NCORP. Again, this was beyond my comfort zone, and again, I don't make the clinical decisions. I let the oncologists make the clinical decisions on which trials they want to open. I provide some ideas of some of the other trials that I see, especially all the prevention and early detection trials. But my research has been in cancer immunology for the last 35, 40 years, something like that. But again, I don't I don't run the clinical trials. I let the oncologists choose the clinical trials.
Yeah, and also interesting that COVID must have been a fascinating period for you to look at what's going on.
We were very active on doing research not only on our cancer patients, but actually in the state of Louisiana, there were several groups, they still are, several groups that are continuing to do research on COVID and the outcomes on cancer patients, as well as on basic science COVID. So my lab did some studies on that, and we continue to do that. So it's a fascinating opportunity. It's a new world, right? These
Yeah.
kinds of pandemics. I mean, COVID was an example, but it's probably not the last example, right?
Yeah, it's kind of an era when Doug Lowey's stuff became page one material, which
Exactly right. And
yours
in
too.
work and working with the NCI during the pandemic was exceptional, really exceptional.
Yeah, yeah. Well, is there anything we forgot to cover? Anything I forgot to ask you? Anything you want to bring up?
Oh yes, there is one thing I want, and that is to and I said it at the beginning, but I think it's important that the the NCORP program at the NCI has been exceptional in allowing us the flexibility of growing these programs in an organic way so that each NCORP finds the best way to grow their programs. And I've seen this over the years. When we started as an NCORP, um, we all were still in the mind of the CCOP, which was one institution, one CCOP. And as all of us started saying, hey, by the way, the Louisiana NCORP has now 10 sites or 14 sites. Oh, by the way, the Colorado one has 5 sites. Oh, and the Minnesota one has. And we've all realized that if we grow this programs and bring the opportunity to offer clinical trials to the patients where they are, instead of having the patients come to us, then it makes the big difference. And I think Warda McCaskill-Stevens' team and herself have been incredibly visionary on that. We just, for example, proposed a new way of using telemedicine or virtual approach to enrolling patients at distant sites, because distant sites all want to enroll, but they have the problem of who's our research nurse, our research personnel. They have the oncologist, they have the physician, but they don't have the research expertise and they cannot hire that research nurse. And so what we're doing is we're providing the research nurse virtually from our central location and helping them do that. And CI has been enormously supportive of testing this, piloting this plan, and we're in the process of doing that.
Well, thank you very much for talking with me, for finding the time to talk with me.